Hey, good afternoon, everyone. I'm Melanie Griffith, and I'm the chair of the Senate Budget and Tax Committee Subcommittee on Health and Human Services, here with subcommittee members, and also joined by Chair Resnick and the House Appropriations Health and Social Services Subcommittee. We have several analysis that we will hear this afternoon. Mr. Chairman, unless you have any questions, we can go ahead and proceed with the budget analyst, Andrew Garrison, who will be presenting MDH administration.
Absolutely, please.
Fantastic. Mr. Garrison, good afternoon.
Good afternoon, Madam Chair, members of the relevant subcommittees. Let me just share my screen here. Can you all see that all right?
Yes.
Excellent. So this is the budget for the Maryland Department of Health Administration. And in addition to the Office of the Secretary and the administrative components, this budget also includes a pretty decent share of the state hospitals. So everything but the DDA hospitals are organized here. So that includes our regional behavioral health facilities, Perkins, the maximum security facility here in the state, as well as our 2 chronic care hospitals. And so because of that, we take this opportunity to discuss some of the overall employee and personnel components of the Maryland Department of Health, as well as specifically looking at those facilities. And so that is why we see a much larger budget than you would expect for perhaps just an administrative components here. The first thing I do want to highlight is some reimbursable funds that came into these hospitals and the facilities in fiscal 20 as part of COVID response. The personnel at the state hospital facilities received additional compensation for coronavirus response as sort of the largest share of this total pie here, but also funding was distributed to acquire personal protective equipment and disinfectants and other things to keep these hospitals running safely because they were still operating during the pandemic. As mentioned at the top, because we do have the state hospitals here, they are, excuse me, they do represent a pretty sizable share of this budget, with employees overall occupying about 77% of the total expenditures that we see here in the administration budget, with over 2/3 of that coming from state hospital employees, and then the rest on the administrative side. And then also, when we focus in on the operating expenditures, a lot of the operating expenditures are on the state hospital side. So again, 60% or so between care for residents, food services, operations. Looking briefly at our budget change here, what we're showing is largely, again, personnel increases. Let me scroll down a little bit for y'all, but in total of a $15.5 million increase, we're able to get 12 of that out of the personnel expenditures that I'm showing on the screen here. We have a few other additional items to highlight at the top under that administrations and operations section. My colleague Ann in the Public Health Administration budget discussed $4 million in infrastructure grants. That's budgeted here in the Secretary's office, and so that shows up here as an increase as well. And then the Office of Finance is going to be receiving some additional contract for outside accounting services, totaling $1.5 million. We're showing that here as well. One other increase on that personnel side is an increase in overtime expenditures. It increases by 1.2 million. And what we show here on Exhibit 6, because those state facilities are here, we do have a pretty sizable component of the state's overall overtime expenditures being shown here. And that increase, that 1.2 million increase, is largely at Perkins. But that increase from 21 to 22 is still well below what those most recent actuals were in 20. And so we still are anticipating overtime being a little bit underfunded relative to what some of the previous closed amounts have been. Additionally, the budget this year in 22 actually reduces PINs across the state hospitals. And what's really driving that, as you can see here in Exhibit 7, is an increase there's a decrease rather in Perkins. The total budget loses 22 positions. We can account 21 of those at Perkins. And so that's offset by some changes in the administrative side and getting some budgets, as well as decreases in the regional BHAs as well. And we have one issue that we want to highlight when we're discussing these budgets, and that does pertain to the state hospitals. Y'all passed two pieces of legislation last year, chapters 572 and chapters 576, that pertain to state employee compensation or at these state hospitals. Chapter 572 totals about 4.7 million in general funds. Those funds, as well as the funding for the other budget, are or for the other legislation rather, are budgeted in DBM's personnel budget currently. So we would expect that money to be entering into the department, totaling about 30 million in general funds. One item pegged different salaries to other like positions throughout the state. Linking security attendant salary compensation with correctional officers or physicians and psychiatric compensation with one another. That totals about 4.7 million in chapter 572. And chapter 576, actually, where we see most of the impact that we'll be seeing from a dollar standpoint. And the first of which I want to highlight is the legislation required individuals who work at facilities with a forensic emission of greater than 75% to be receiving compensation like that at Perkins, which is the state's only maximum security facility. And because of that, prior to chapter 576, employees at Perkins got a little bit more than some of their counterparts at other state hospitals. For instance, nurses, both registered nurses and direct care and LPNs received more at Perkins than they would at Spring Grove or Springfield or some of our regionals. Chapter 576 changes that, costing or with the estimated expenditures of 7.8 million, again, also in the DBM personnel budget. Another thing that occurred under this legislation would be only certain classes of employees at Perkins were receiving additional compensation. The nurses, the security attendants, while social workers, for instance, and therapeutic staff like therapy recreators were not. And so it raised everyone else at Perkins to also be at a higher grade than they would have been otherwise. And then it also required staffing ratios, staff to patient ratios, particularly for security attendants, to be 3 to 1 from patient to staff rather. And so first, looking at that forensic admissions, we would expect Chapter 576 to apply to all of our regional BHA facilities, in addition to Perkins, of course, as well as that red line on the screen is a DDA facility, the Potomac Center, that has recently crossed into having a larger share of their admissions be forensic or court involved. So individuals who are either not criminally responsible or incompetent to stand trial largely. And so with that, we would also expect the DDA staff as well to be receiving those compensation increases. Looking at Perkins in particular, and then moving on to that staffing ratios, which is funded at an estimated 15.6 million in fiscal 22. Particularly the security attendants are the ones that are required under those staffing ratios to be at a 3 to 1 from a patient to staff. And the allowance has 92 such positions, which would mean that by DLS's calculations that only 5 security attendants couldn't be working at any given time at Perkins. And given some of the existing concerns with overtimes, as well as some of the vacancies, we are asking the department to comment on how they're going to be able to meet the new staffing requirements under Chapter 576, given this pin reduction and given some pre-existing concerns on overtime. The other thing to highlight when we're looking at these state facilities is that while court-involved populations has been increasing across the board at all of our state hospitals, another factor to consider is that it's more common for individuals at Perkins to be stepped down to one of their regional facilities than it is for individuals at a regional facility to get bumped up to Perkins. And that's just what we're showing here in Exhibit 10 as to how that historically happens. All things considered, it is still fairly rare on either end, but it is more likely that someone would be moving up in care than down. The only other thing we're highlighting in this budget is major IT projects. This is where we see a lot of the funding for the major IT projects, and a lot of them, all of the ones in prior years were actually extended, or rather cost increased for all of the projects that we're continuing. And we're showing there on these 3 projects, there was an additional project that was added this year to convert the department's phone system to a voice over IP. And so that wasn't considered here because it's not pre-existing. But but ultimately, DLS is concurring with the governor's allowance. That concludes my presentation, and I'd be happy to take any questions.
Thank you, Mr. Garrison. Are there any questions for the analyst members? Okay, going once. I see no hands, Mr. Garrison. So we will move on to, I believe I saw the Acting Secretary Schrader and his team join the Zoom. So Mr. Secretary, if you want to begin and introduce the members of your team that you have with us or that will be presenting. Good afternoon.
Good afternoon, Madam Chairman and members of the Joint Committee. I want to start by thanking the analysts for their analysis. I'm joined today by Deputy Secretary Chief Chowdhury, who will be answering a number of the questions. We have Jordan Butler, our CFO, John Robeson, who is the director of our hospitals, and then I'll let Atif introduce the rest of the team when the time comes. We agree with the analysis, and I did want to thank the committee for their forbearance on a number of JCRs that are in progress. And of course, as we all know, with the COVID, it's been difficult pushing a lot of these reports through, but they are in process. And I believe there was a question about the staffing of the state hospitals, and I was going to ask Deputy Secretary Chowdhury to address that. So, Atif?
Great, thank you, Mr. Secretary. There was a question regarding the security attendant over at Clifton T. Perkins Hospital Center. There is Senate Bill 693 was passed last legislative session, which issued a new requirement that becomes effective on January 1 of 2020, which is going to require a 3-to-1 staffing ratio, security attendants, staff to security attendants at the Perkins Hospital Center. We are currently meeting and actually exceeding that requirement now. So when this bill does go into effect July 1 of this year, we will have no problem meeting it. And we do want to reiterate our new methodology for PIN allocation, which is a more global approach. We don't necessarily look at PINs being in one particular hospital budget, but we look at the overall hospital system in order to determine the number of PINs that are needed based on needs, based on clinical need for the patient. And we have the opportunity there to shift around PINs as needed. The department in general as well also does the same thing, where PINs from one unit or one administration within a department are also shifted to another based on need, and in particular in the hospital based on clinical need and to ensure patient care, adequate patient care.
Excellent, thank you. Thanks.
And Madam Chair, I would also mention that Marion Fogan from our Perkins, the CEO of Perkins, is also with us if there are any questions for her about Clifford T. Perkins. And with that, I'll turn it over to you, Madam Chair, for questions.
Thank you, and thank you very much for those responses. Are there any questions for the agency? Okay, Delegate Valentino Smith.
Thank you, Madam Chair, and thank you, Secretary Schrader and your staff for the work that you're doing. If I had 2, maybe 3 questions. One for Mr. Butler. You know, do you have some kind of ledger that you can help us with the amount of federal money that we've been given in the various care packages in terms of what's already been spent, not only just here in this budget, but spent by the department and what you still have to spend and the buckets that money would fit into? I'm trying to keep like a little abacus here of how much we still have that we can spend in MDH and if any of it's designated or some of it's discretionary.
This is for all the COVID-related federal funds that we've received?
Yes.
Yes, we can provide you detail of those various pots.
Okay, thank you. Madam Chair, if I may, a second question?
Sure, proceed, Madam Vice Chair.
Thank you. So with respect to testing and PPE in the state-run facilities, So early on, I know that we had some briefings and talking about whether they were getting a sufficient amount of PPE for all of the staff, you know, from custodial up through all of the healthcare personnel, and where we're standing with respect to adequacy of PPE and what kind of testing is being offered to the employees in the different facilities, and the timeliness on how long it takes to get their test back, or what testing is going on with respect to the patients or clients of the facilities. And are you having enough tests?
Yeah, I would ask our hospital director, John Robeson, to address that question. John, are you available to answer?
Sure. Plenty of and adequate PPE presently and throughout the pandemic, I'm happy to report. And from a testing perspective, we are testing no less than monthly all employees. We change that algorithm if we have an active outbreak with a positive employee or patient. So it really depends on the number of positive tests that we get. The turnaround time for those results is averaging about 48 hours. And all of those tests, whether patients or employees, are being run through the Maryland State Lab.
Have you
Go ahead.
vaccinated? What's your vaccination rate like now?
There's not any facility below a 55% rate from an employee perspective. Interestingly, the patient vaccination rate is much higher. To date, we've vaccinated 647 patients and a little north of 1,500 staff.
I appreciate you continuing to give us updates on the percentages as we move through session. Thank you, Madam Chair.
Thank you for your questions. We'll move to Delegate Young.
Thank you, Madam Chair. Ms. Secretary Schroeder and staff, just wanted to get a follow-up. I got Spring Grove in my district. I've talked to folks who have been working there considerably. And obviously before the pandemic, one of their largest impediments to getting the job done was they were still using paper documents as opposed to electronic documents. I know there's been ongoing work to alleviate that. I was hoping you could either provide for us or maybe after this a timeline for when that will be complete and when they can expect to be using electronic documents in a modern sense rather than paper documents for their the people that they care for. Thank you.
I'll just start. We have an ongoing project in process for EHR. Of course, the situation we're in has slowed us down some, and the budget, is going to extend the timeline. But I don't know if John Robeson, if you wanted to address the progress we've made so far. I know we've been working with all the hospitals to develop that project.
Sure, it has been a daily work project for the past 3 or 4 months. We had presentations, verbal presentations by selected vendors that made it through the vetting process of the selection committee. And actually tomorrow and Wednesday of this week, we will have round 2 of those oral presentations to hopefully come to a final decision on vendor selection. So I think we're very close and should have that decision reached by Wednesday of this week.
Excellent. That's a decision on vendors that would then work towards modernizing and moving from paper documents to electronic documents, correct?
Correct.
Understood. Thank you very much, Madam Chair.
Thank you. Vice Chair of Budget and Tax, Jim Rosapep. Senator, you can proceed.
Thank you very much, Madam Chair. You said that 55% of employees have been vaccinated. Did I understand that correctly?
That's the lowest percentage of patient populations by facility. So I have a grid in front of me that has the numbers of vaccinated employees by facility. We're as high as 91% at Rico, Baltimore, 84% at the Finan Center. The lowest hospital right now is at 55% of employees.
Okay, so that's employees. That's why I want to focus on employees.
Yes.
So why is the one at 55% at 55% of the one at 95% at 95%?
The willingness of staff to roll up their sleeve and accept that vaccination. So we do education, encouraging folks.
Right.
It's not about the access to the vaccine itself. It is about comfort level of staff to receive that vaccination.
And I understand that. And that's true with all the hospitals in the state. And what I'm trying to understand is what have you learned? Because the difference between 55 and 95 or whatever, 90, that's huge. So is it the characteristics of the staff in a particular place? Is it the culture of the staff in a place? Is it the age of the staff members? Have you got any pattern for what's working and what's not working, or where it's working, where it's not working?
No, we don't have any pattern or any common denominator of what leads to a higher participation rate amongst staff. So again, it's a daily campaign with leadership rounding and talking with staff and encouraging them to sign up for a future clinic.
And one last question, Madam Chair, if I may. How often are you offering the vaccines to employees in these facilities? And how quickly, if I say, okay, I'm ready to get one, do I get it like the next day, or am I scheduled for 3 weeks out?
Our initial vaccine allocation was 2,900 doses, and that arrived on December 24th. And we've had numerous clinics between 3 and 4 at each facility. We have 150 doses remaining in our vault today, and we have 200 more anticipated doses coming on March 1st. So if someone were to say, I would like a vaccine, we can do that very quickly. If not that day, the next day.
Thank you. Thank you, Madam Chair.
Thank you, Senator. Are there any other questions for the Secretary and his team? Okay, seeing none, we do have a few public witnesses, so thank you all for your responses and your questions. We have Denise Gilmore and Cari Elliott, both with AFSCME. Good afternoon.
Good afternoon, Chairwoman Griffith and Chairman Resnick and members of the committee. Thank you so much for giving us a chance to testify. My name is Denise Gilmore. I'm a field director with AFSCME Council 3 in our state psychiatric facilities and chronic hospitals. We represent nursing staff, clinical staff, housekeeping, grounds, building services, members of the rehab department. We really do have a big bulk of the members that are there. I'm going to keep my remarks relatively short today. I wanted to first just acknowledge the tremendous work that our facilities have done in this last year dealing with the pandemic. We're very proud that these long-term care facilities have done, relatively well, certainly considering their counterparts in other places in the state. So, I do want to acknowledge that. I also really want to acknowledge and thank the members of this committee for their support with the additional funding into our forensic facilities. It's really going to make a big difference. We do have a member who's going to talk a little bit more about what's happening specifically in chronic facilities, but I wanted to just highlight, a few areas of concern that still persist. Obviously, vacancy rates are still high across our chronic facilities. As of December 31st, 2020, there was a vacancy rate of about over 11% for chronic facilities. I also want to just really highlight the need for security personnel. And again, thank you for the additional funding that'll help with making that happen. Perkins as a maximum security facility, obviously, should be in the 1 to 3 security attendant to patient ratio, according to the funding in this new chapter. But it's also very important that our regional hospitals see an increase in security. In the last 2 years, we've had 2 members who were sent off via shock trauma as a result of assaults on their patients, one at Spring Grove, one at Springfield, in large part because there wasn't an armed security presence that's not at all what I meant, a security presence, trained security presence on the unit at the time that the assault happened. So, we anticipate that as a result of this, the security ratio in regional hospitals should be 1 to 12. And we would just like to see, what the department is going to do to make that happen. It's critical that we add more security there too. And then finally, I would be remiss if I didn't note that, we see that the populations in these facilities have gone up. The average daily population has gone up, but there is that PIN reduction. So, we're obviously very concerned to see additional PIN reductions out of this budget. But with that, I will hand it over to Cari Elliott, who is a member of ours at Deer's Head Hospital in Salisbury. Thank you very much.
Thank you. Good afternoon, Ms. Elliott.
Good afternoon. My name is Cari Elliott. I am a member of AFSCME Local 1081, and I'm a geriatric nursing assistant at Deer's Head Hospital in Salisbury. I do direct care in my facility for those that are there that because they have chronic illnesses. I love doing my job. I love taking care of these people, and they're the reason why I get up and go to work in the morning. But we need more resources to be able to provide better care for these people. I've been at Deer's Head for 10 years, and in that time, I have seen staffing levels go down. During this pandemic, our interactions with our patients and everything, we have been their lifesavers because where visitations have been suspended, and we would like to spend more time with them because they feel like they're lonely, they're getting depressed. I currently work on a total care unit with patients who have dementia and traumatic brain injuries. When they first opened this unit, they had up to 8 staff working on it. Now we only have 5. We need more people to keep an eye on this population because we do have ones that do wander, and we need to make sure that they're not unsafe, they've fallen or anything. Like yesterday, we only had 2 GNAs on my floor. There are 7 patients that are on my floor that need assistance with eating meals. We only have 20 minutes, and 2 GNAs and 7 patients to feed is really tough to try to get everything done. I feel bad for our residents because we like to spend that time with their meals, interacting with them, and they really open up to us to let us know what's going on with them, how they feel. To alleviate some of the stress of overtime, my facility has actually brought in more and more temp agency staff coming in. They really don't know our residents. We have to work really quickly to get them up to speed on our residents, on how to take care of them, what to look for. And then when they are there, we still have to constantly keep going back and checking on, make sure that they've done everything correctly and either in their paperwork or they have done their care the way it's supposed to be done. And our residents really would like to have the same people every day. We don't have the same people every day going in there to them when you have temp agency. And they are more comfortable with the ones they see every day. So if we had more staff, we would definitely have a better quality of care for these people. And because dementia and traumatic brain injuries, it's come to me personally in my life that they need the constant people in there. And then lastly, I would like to advocate for our housekeeping staff. They are constantly running back and forth trying to make sure everything is wiped down. And I mean, they actually need more people there. We only have like maybe 1 person on the floor that actually wipes down everything for us. And we actually need more than that. We do what we can to help them, vice versa. I mean, we go above and beyond what a geriatric nursing assistant really should be doing. And I mean, other than that, I mean, we have had very, very low. We only had 2 patients in our facility that actually have come down with COVID. We did have 1 that did pass away. And as far as I know of, I know mostly everybody has been vaccinated. We might have some that are still pending if they want to get it or not. It's very low, but I've received both of my doses. So I'm glad that I got to be able to do that. And I just want to thank you for listening, and thank you for continuing to support our patients and my coworkers and myself. Thank you.
Thank you so much for your testimony and for sharing that firsthand information from your vantage point. And we're certainly sorry to hear about the loss that you all experienced. Colleagues, are there any questions for these witnesses? Okay, thank you all very much. Seeing none, that will conclude the hearing on the MDH administration budget. Members, you should have received notification this earlier that we have a presentation from the Office of Legislative Audits. Mr. Adler and Mr. Kofi are here from the state's office. Good afternoon.
Good afternoon. How are you?
Thank you very
Good.
much. We're doing well. You can proceed.
Thank you. Good afternoon. My name is Josh Adler, and I'm an Assistant Director with the Office of Legislative Audits. I'm here today with Brendan Coffey, Information System Audit Manager, to discuss a number of findings from our audit of the Maryland Department of Health Office of the Secretary. As noted on page 2 of our PowerPoint, this audit report includes 6 budgetary units associated with the Secretary and Deputy Secretaries that provide administrative infrastructure and oversight to MDH and health providers throughout the state. During fiscal year 2019, expenditures for these units totaled approximately $72.7 million. The report included 6 findings, of which 4 findings were repeated from the preceding audit report and appear in our current audit as 3 findings. Notably, in our prior audit, we reported that MDH's accountability and compliance level was unsatisfactory. However, based on the results of the current audit, we have concluded that MDH has made improvements and is no longer deemed unsatisfactory. Proceeding to page 4 of our PowerPoint for finding 1. We noted a repeat finding that MDH didn't provide adequate oversight of its over 192 interagency agreements valued at $210.2 million that MDH administrations entered into with state agencies, of which the majority were state institutions of higher education. Our review of 20 of these interagency agreements, totaling $41.6 million, disclosed issues such as MDH administrations used 11 interagency agreements to inappropriately augment staff beyond budget positions. These interagency agreements include 62 positions which were for non-health specific duties, such as policy analysts. 2 interagency agreements totaling $2.8 million had administrative rates which exceeded the maximum allowed under MDH policy and appeared excessive. For example, one of these interagency agreements had an administrative rate of 55%. Finally, MDH couldn't support 5 payments and 5 different interagency agreements totaling $1.2 million. Turning to page 5 for finding 2, which again is a repeat finding from our prior audit report. We know that MDH didn't always comply with state procurement requirements related to sole source and emergency procurements and publishing contract awards. MDH couldn't adequately justify the use of the sole source procurement methods for 2 sole source contracts, totaling $3.2 million, that were awarded to incumbent vendors. MDH didn't negotiate pricing or notify the Board of Public Works for 1 emergency procurement, totaling $561,000. In addition, 5 contract awards totaling $235.5 million that were awarded between May 2016 and March 2019 weren't published in the Maryland Marketplace as required. Proceed to page 6 of our PowerPoint for finding 3. We found that the Office of Inspector General didn't always conduct comprehensive reviews during its audits of local health departments. During fiscal year 2018, payments to 24 local health departments subject to audit totaled approximately $294.9 million, of which $120.7 million was for contractual services and $174.2 million was for payroll. Our test of 5 Office of Inspector General audits during fiscal year 2018 disclosed that the OIG audits of local health departments didn't always include a comprehensive review of contracts and related expenditures, payroll, and user access. Relating to contracts and expenditures, we know that for 4 of the audits tested, the OIG didn't verify the local health departments properly procured the contracts and didn't verify the propriety of the related expenditures. Proceeding to page 7 of our PowerPoint for finding 4. We know that MDH hadn't established adequate controls to ensure the propriety of payroll payments, leave balances, and timesheets. MDH's payroll expenditures totaled $521.7 million in calendar year 2018. For example, we know that MDH's central payroll unit approved timesheets for employees without making sure that the employees worked the recorded time. That is, when an employee supervisor didn't approve their timesheet before the deadline, MDH's central payroll unit approved the timesheet without any direct knowledge that the employee actually worked the recorded time and didn't retroactively find out whether the time recorded was correct. According to MDH's records, for just one pay period, we know that about 8% of the hours worked by MDH employees were approved by the central payroll unit under this scenario. Finally, on page 8 of our PowerPoint, we comment on 2 information system findings. In the first of these findings, we know that MDH's network intrusion detection system wasn't set up to stop malicious traffic from entering networks from untrusted sources. The next finding, which is a repeat finding from our previous audit report, we know that information technology contractors had unnecessary network level access to numerous critical MDH network devices because their network traffic wasn't subject to traffic filtering. We were advised by MDH personnel that it didn't maintain a centralized schedule of all information technology contractors, and therefore MDH wasn't aware of the details concerning the presence of these contractors and the extent of unnecessary network level access. This concludes our presentation of the Maryland Department of Health Audit Report. Thank you so very much for your interest in this. We'd be more than happy to answer any questions you may have.
Thank you very much. Are there any questions for the Office of Legislative Audits? Okay, seeing none, thank you, Mr. Adler, Mr. Kofi. Mr. Secretary, we know that there was a scheduling modification, and so we know that you might not be completely prepared to respond, but certainly wanted to give you an opportunity if there is a response you'd like to make at this time, and then you can follow up with us in writing if there are additional details.
Thank you, Madam Chair and the committee. I actually would like to comment because this is a very critical part of what myself and Secretary Neal have been working on for the last 4 years. To us, internal controls and the working with the auditors to make sure that our audit findings are commensurate with a well-run organization has been one of our top priorities. I will say that we work hand in glove with Mr. Doggett and his team, and I'm very pleased that the coordination that we've had over the last 4 years between the auditors, Mr. Adler and his team, and Mr. Doggett and our operational team has been very focused on improving our internal controls and minimizing audit findings. I think in this particular audit, we've made a lot of progress. It's never going to be good enough in our estimation. We always have to be on our toes. 3 years ago, when we found out about the problems with the interagency agreements, we aggressively went after it. We've made improvements. And I'm going to ask our Deputy Secretary Chowdhury to comment on this in a second. And then the other thing we've done is we have created in the last year a Chief Information Security Officer, Mr. Otwell, who's highly experienced in this area, who is coordinating very closely with Chip Stewart from Do It. So that's making sure that we have very tight security in our systems is one of our very top priorities. And again, as I said, we've made progress, but not enough. I'm going to ask Mr. Chowdhury to comment, and then we'll turn it over to Fred for his comments. Deputy Secretary Chowdhury, did you want to comment on the IAs and what we've been doing there?
Sure, thank you, Mr. Secretary. So we've been taking a comprehensive look at our MOUs and IA processes, our interagency agreement processes. We've been coordinating extensively with the Office of the Attorney General as well as the Office of the Inspector General to ensure our new framework and newly developed framework for interagency agreements complies with all audit findings, and there wouldn't be any additional repeat findings. We're also coordinating with our MOUs to determine when MOU should be utilized, when interagency agreement should be utilized, and developing frameworks and methodologies that can be passed along to all the various administrations within MDA to ensure we have proper compliance and consistency across the board to ensure that findings like repeat findings such as this do not happen again.
Thank you. Sure. And I'll turn it over to Mr. Doggett for his comments, and then we'll take questions.
Thanks, Mr. Secretary and Madam Chair. Thank you for the opportunity to be here. I just want to echo what the Secretary said regarding the great relationship among the key parties here, leadership, department leadership, Josh and his team at OLA and the OIG. We've certainly been empowered, the OIG has the last several years to help trace and track down these audit findings, these very difficult findings in some cases, and try to help the department get them resolved. So again, we appreciate Josh's help in all of that, and I'm happy to answer any questions.
Thank you very much. Are there any questions for the Department of Health in response to the auditor's recommendations and findings? Okay, I'll raise one. Mr. Secretary and your team, thank you so much for being here and for making progress on the findings. I am particularly interested in repeat finding number 2 that pertains to the e-Maryland marketplace. Can someone, I'm not sure who best to respond, to tell me how we're making progress? That's a significant amount of awards totaling $235 million that weren't published during that 3-year period on e-Maryland marketplace. Can you tell me what steps are being taken to make sure that we utilize that tool moving forward?
So I'll start, Madam Chair, and then ask Deputy Secretary Chowdhury to follow up. We've recognized that we need to improve our contract administration and procurement. We've empowered Mr. Chowdhury to do a top-to-bottom re-engineering of that, and we have embraced the State Office of Procurement working with us now to do end-to-end assessment of how things are put together, and our objective is to make substantial improvement over the next 12 to 18 months. I'll turn it over to Deputy Secretary Chowdhury, but I did want to say this is one of our top priorities to get this squared away. So Deputy Secretary Chowdhury.
Thank you, Mr. Secretary. And Secretary Schrader has made it very clear that he wants to ensure that we have a very robust procurement department that meets the needs of the department, as well as ensure that we follow all applicable laws, rules, and regulations. As the Secretary indicated, working very closely with the Office of State Procurement to revamp our procurement department. We're actually expanding it, adding additional employees to manage the workload of the department. We're a very large department, and our procurement wasn't right-sized for the department. So that's one of our goals moving forward is to right-size that, ensure that we have compliance with all requirements for advertising of various procurements. And as we move forward, we are working very closely with all our staff across the board to make sure there's consistency when it comes to procurement. We do have various facilities that do procurement. We have various administrations that have procurement officers within them. So we're looking at an across-the-board framework to determine, to ensure that we have consistency in operations and make sure that we are in compliance with all requirements for posting on EMA, as well as all other requirements for procurement as well.
And Madam Chair, I would say this is going to be a heavy lift for us. We, for a department our size, I want to see a dramatically improved contract administration and procurement operation. We've entrusted this to Deputy Secretary Chowdhury, and I've insisted that we get the right number of people focused on this and trained, and we have embraced both DO-IT and DGS in being partners with us, so we up our game in this area. So thank you for asking, and this is something we're very committed to.
Well, I appreciate that response and your laser-like focus on this. As you probably know, Chair Resnick and I spent some time this interim trying to help streamline that process. And certainly Senator Eckert and I on the work group on equity and inclusion spent some time trying to, make sure that we're creating opportunities for equitable access to these contracts. And if the announcements aren't published, then there's not an opportunity for MBs or even others to bid. And so we're pleased to hear that you have someone focused on this and look forward to hearing progress again next year in this area, if not before. Now, do any other members have questions for the Secretary or his team related to the audit? Okay, we thank you all very much for the presentation and the responses and look forward to hearing back any updates that might come in between this and our next time together. Thank you all very much. That concludes the audit hearing. Thank you, Mr. Adler. All right, colleagues, we're now going to turn to the DHS administration. We have our analyst, Ms. Grace Patterson, is going to do our presentation. Good afternoon, Ms. Patterson.
Good afternoon, Madam Chair. Thank you. So it's my pleasure to present the Department of Human Services Administration Fiscal 2022 Budget Analysis. The administration budget unit is involved with a variety of operational activities from financial services to IT management. As you can see here, the overall budget increases about 20 million or almost 8%. And this is mostly driven by the MD Think project or the Human Services Shared Platform. So the MD Think project has been a significant effort for the agency since fiscal 2017. The goal of the project is to both update legacy human services systems and completely replace them, and also build in communication between the human services systems. The components of the project are planned, the child, juvenile, adult management system and the eligibility and enrollment system are planned to conclude development in fiscal 2021. So in fiscal 2022, they will be in maintenance and operations, and the state receives a diminished federal fund match for maintenance and operations activities than it did for development activities. The entire MD Think project receives an approximately 75% federal match, with general funds making up 25%, but maintenance and operations activities receive an approximately 50% federal match. I'll come back to the MD Think project later on in this presentation, but I'd like to start off by talking about a couple of performance measures. Last year, the committees were interested in the proportion of children in out-of-home placements receiving appropriate physical and mental health services. In 2020, this rate remains low. It's 42% in 2020, and it was 41% in 2019. However, new is that there was a substantial decline in educational services provided to children in out-of-home placements that were deemed appropriate. In 2019, this was over 90%, but due to the DHS indicates that due to school closures and lack of access to devices, fewer children were able to receive appropriate services. Another performance measure I wanted to bring up is MBE participation. MBE participation for the agency increased in 2018 and 2019, but saw a 2 percentage point decrease in 2020. And that rate is approximately half of the state's 29% MBE participation goal. DLS asks that since 2018 and 2019 performance increased due to the MD Think project, how it plans to attain MBE participation after the MD Think project concludes in fiscal 2022. Moving on to the budget discussion, the DHS administration receives 6.4 million federal fund deficiency for the MD Think project. Available data submitted with the governor's budget indicates that there was sufficient funding available. However, DHS and DBM have since indicated that this is not the case. The budget books anticipated that 17.4 million available from fiscal 2021 after all fiscal 2021 expenditures would total 17.4 million to support 33 million in expenditures, whereas only 15.9 million are provided in funding for that year. So the project's funding stream and level of expenditure has is indicated to not be accurate by DHS, and as DHS has since submitted data indicating that the total project's cost has decreased 10 million, but in the time available, DLS was unable to confirm this estimate. So given that the data available has changed within the past couple of months, DLS recommends restricting funds in DHS, DBM, and DO-IT pending submission of a report on cost estimates that all three agencies agree on. Continuing with the budget discussion, the Office of Technology for Human Services comprises about half of the allowance. And this is accounting for maintenance and operation costs of CJAMS and E&E, which will move into this program and out of the major IT program in 2022. As stated earlier, the general fund increase is substantial. It's almost 50%, while federal funds decrease 18%, and that's reflecting the change in the federal matching funds available. Another significant change in the budget is that 35 positions are removed. However, these were all long-term vacancies, and DHS indicates these won't have a significant impact on service delivery, and the removal of these positions translates to a 2.2 million decrease from the fiscal 21 working appropriation. So moving on to the one issue I have to discuss today is how MD Think is preparing for the project's conclusion in fiscal 2022. The project is aimed to both reduce expenditures on expensive legacy systems, while also improving the communication between systems and other agencies as part of an effort to implement no wrong door service delivery. However, these goals, the ability of the project to meet these goals is uncertain given recent trends in the that DLS has seen with the project. The DHS notes that before the project started, maintenance and operations costs for legacy systems totaled 72 million, while after the project they're expected to be 90 million, representing a 25% increase in maintenance and operational costs of human services IT systems. In addition, the project is meant to facilitate communications between various agencies' IT systems, but two agencies have recently canceled their migration to the platform, citing cost concerns and the amount of modifications it would take to make their systems compatible with the cloud hosting platform. In addition, there's no quantitative evaluation of the system's efficiencies yet, so DLS requests the agency comment on that. The biggest concern is that several systems are several months delayed. While the child welfare component of CJAMS was deployed statewide, it took 9 months to progress from pilot deployment to statewide deployment. In addition, the adult services and juvenile services components of CJAMS are several months delayed. The eligibility and enrollment system is also delayed. So each of the outstanding systems in CJAMS and E&E are planned to be deployed before the end of fiscal 2021. However, it's only within 3 months or so of the end of the fiscal year, and DO-IT oversight concludes in fiscal 2021. So this raises concerns if there are further delays pushing statewide deployment into fiscal 2022, there will be no DO-IT funds budgeted for oversight in that fiscal year. The child support management system is planned to be deployed in fiscal 2022, and there is due oversight funds budgeted for that. Going on to the recommendations pertaining to MB Think, DLS recommends a spending and development timeline and quarterly reports providing updates with respect to that timeline. And that concludes my presentation. I'd be happy to take any questions.
Thank you very much. We'll turn it over to the subcommittee chair, Chair Resnick. I think you're muted, sir.
Sorry, I will thank Grace again. Thank you for the presentation. A couple of quick questions. One is, you noted that all of these, the list of applications that are still not deployed. Can you tell me what is deployed, if anything?
The child welfare component of the CJAMS platform and the long-term care application is deployed. The health benefit exchange has successfully migrated to the platform, but of the core human services systems, the eligibility and enrollment system remains outstanding, and so does the juvenile services and adult services components of CJAMS, in addition to the child support management system.
So I remember last year, the long-term care component was deployed as well. I remember hearing from the long-term care community that there were issues with submitting invoices, getting payments, adding data. Do we know if any of that has been cleared up or fixed?
DLS hasn't received any data about that, but the agency might be better to comment on that.
And so basically the child welfare system application is the only thing that we have seen deployed since last year's budget hearing. Is that correct?
Yes, it was deployed over the summer.
Okay. And have we heard anything about data migration and use of the system from other non-DHS agencies? Department of Health, Juvenile Services?
I haven't heard anything specifically, but the agency might be able to comment.
Okay. All right, thank you.
Thank you. Are there any other questions for Ms. Patterson? Okay, thank you very much for your analysis. We will now turn members to the Secretary Padilla and your team. Good afternoon. If you want to introduce those you have with you and your responses to the analysis.
Thank you, Chairman Griffith and Chairman Resnick, for the opportunity to discuss the FY 2022 budget allowance for DHS administration. I have my team here with me today: Subramanian Munyasamy, Chief Technology Officer; Gregory James, Deputy Secretary for Operations; and Stafford Chipongo, Chief Financial Officer, who is with us virtually due to the weather. I want to take the time to thank Grace Patterson for her comprehensive and concise analysis of DHS's budget. She's a pleasure to work with, and we appreciate all your support, Grace. In previous hearings, I have thanked our local directors and the staff of our 24 local departments of social services, and I will do so again today. They're essential to the work we do on behalf of the children, families, and vulnerable adults. But today, I also want to recognize and thank the many women and men in the DHS administration units who are also essential to fulfilling our mission and have gone above and beyond to meet the challenges of the COVID-19 pandemic. Let me highlight two of these two units. The Office of Technology for Human Services. When the pandemic required us to move from office work to telework, to protect the health of our clients and staff, this team worked to obtain, set up, and deploy hundreds and hundreds of the tools our workers need to be productive in the telework environment, including laptops, tablets, smartphones, wireless hotspots, and VPN accounts. This was a Herculean task, but they got it done, and they continue to solve problems and support DHS as we adapt to the new remote work world. I'm also going to mention the Division of Administrative Operation. This team, which includes our Office of Emergency Operations, obtained the personal protective equipment, things like masks, gloves, and face shields that we needed to keep our workers safe, coordinated with the food banks and our other community partners to support emergency feeding and hunger prevention activities. Work with landlords and local staff to add physical barriers, extra cleanings, and other social distancing modifications to keep clients and workers safe. And while we're still continuing all of their other essential daily duties, like the daily printing of notices and all of the other tasks that keep the lights on and our programs running. I could continue and cite examples large and small of how each of the administrative units, human resources, budget, procurement, and all of the others have shown dedication, innovation, and resilience in the face of this pandemic. Without them, there is no DHS. Thank you for allowing me to recognize these important members of the DHS team. My testimony at the department's overview budget hearing earlier this month also covered the administration. Rather than repeat that testimony, and in the interest of time, with your permission, I'll move directly to the recommendations and issues. On the recommendations, the department concurs with all the recommended actions. Turning to the issues, in response to issue 1, regarding the progress DHS has made to improve healthcare services for children in foster care, particularly in the context of the COVID-19 pandemic. As reported in the analysis, DHS has been working on multiple strategies to improve the quality and consistency of healthcare services for the children in our care. COVID-19 clearly had a major impact on these efforts. At the start of the pandemic, we had many months of uncertainty. People, including healthcare professionals, needed to learn and implement the safety protocols and measures needed to prevent the spread of the COVID-19 virus. Many healthcare professionals also shifted to focus only on emergency services. And naturally, this was also a time of stress and concern for our foster parents, providers, and staff, all of whom wanted to keep the children safe and well cared of, but also keep themselves, their families, and co-workers safe. All of these factors had an impact on our ability to provide routine healthcare services for children in our care. In recognition of this, DHS adapted and modified our practices. In response to the challenges regarding access to medical care during the pandemic, we have worked hard with our sister agencies, as well as our providers, to mitigate the risk of infection among staff, providers, and the children and youth in our care. We're using telehealth to bolster in-person visits for regular checkups and entry assessment. Scheduling of routine dental services is progressing, but we continue to monitor access challenges that impact timelessness of service delivery. DHS is also partnering with the Department of Health Testing Task Force, part of the Office of Healthcare Quality, to provide rapid COVID-19 testing for youth entering a group home or similar placement at the facility or the local DSS office. And we have been amending our internal child welfare policies in many ways to adapt to these new challenges. Beyond COVID-19, we're taking other steps to improve the monitoring and delivery of service in FY 2022, including we're developing a new report in CDMs on critical healthcare related activities, such as an initial medical assessment and regular preventive care checkups. This report would give our chief medical director a timely information on activities across the system, and in doing so, it will provide insight on what is working, where we have challenges, systematic issues that need attention, and offices or team that may require some additional support or technical assistance. To complement our internal reporting infrastructure and enhance our necessary health information, DHS will be engaging with CRISP, Maryland Health Information Exchange, to access additional healthcare information about the children and youth in our care. On issue number 2 on page 6, regarding the efforts DHS is taking to reach its MBA goal, the majority of DHS contracts are awarded to nonprofit entities. And I think it's very important for all of us to know that which cannot be counted as MBEs under the MBE program, which create challenges to reaching our MBE goal. DHS plans to increase its MBE participation in the future by leveraging the Small Business Reserve Program. We plan to work closely with SBRs through outreach to ensure they become cross-certified as both MBEs and SBRs when possible. It is our intent of DHS to increase the department's overall MBE participation through SBR designated procurement. We believe this approach will help mitigate any loss of MBE participation with the MD-Think program transition. On issue number 3, regarding an updated and ongoing report of the MD-Think timeline and budget for fiscal 2022, the department concurs with the recommendation to provide updated reports regarding MD-Think. On issue number 4, regarding how DHS work with other agencies on the possibility of integration of new systems or the migration of legacy system onto the MD-Think platform. First, it is important to know that DHS works in collaboration with DO-IT when considering whether a project might be appropriate for MD-Think. The department has established a process for other agencies considering coming onto the platform, including an onboarding checklist. This process starts with a high-level discussion of the project scope, the timeline, and the objectives. The parties also review the MD-Think platform requirements, available and supported services, technologies and functions, and a crosswalk this with the agency's current and desired system requirement and program needs. Agencies often want to improve their system, not just move their system. I think that's important to keep in mind of. We also explore other related issues like software licensing and hosting options. Based on these discussions, the agency and the MD-Think team developed then a scope of work and budget estimate for the project and develop an MOU to formalize the relationship. When the new project commences, the MD-Think assigns a project manager to work with the agency, and the work moves forward according to the agreed work plan with monthly invoicing for the services provided and daily, weekly, and monthly discussions to review progress, activities, and issues. This is the process we have been using, but it's also important to remember that MD-Think is very new, and it is a significant change in how we approach IT projects in Maryland. We will continue to refine and mature our processes in collaboration with participating agencies to implement improvements and best practices wherever possible. On issue 5, regarding commenting on how DHS plans to evaluate efficiencies over by the new system, let me first give the committee one clear, concrete example of the benefits we have already seen with MD-Think. The new child welfare system, CGMs, replace the system that we all know as CHESI, went fully live statewide last July, despite the pandemic, with our staff teleworking, which is a big milestone accomplishment. For 22 local departments, CGMs was deployed entirely virtually. Because CGMs is cloud-based and so easy to use, we were able to train our workers and get it into their hands without the usual weeks of in-person training and on-site support. This is something that no other state has been able to achieve ever, and it helped us avoid delays in development and deployment that could have proven very costly. With the traditional system, we would still be waiting to deploy nearly a year later. And we did this because the local departments were asking us to move forward. They knew that CGNs would be a game changer, and they wanted to get it in their workers' hand. Once they had this tool, our workers were able to perform their work at home or in their fields just as easily as they could in the office. They could work where and when they needed to. As much of their duplicative work was also eliminated. No more taking notes by hand and then typing them back into the office, into the system in the office. Now they can dictate notes directly into the system. All of this meant that Maryland was much better positioned to respond to COVID-19 pandemic than many of our sister states. As we look to the deployment of the remaining major applications, the department is looking at several different ways to evaluate the efficiencies and benefits of the new MDThink system, such as how many clients are using the new MyMDThink online portal for things like filling applications and recertification, checking on case status, and submitting changes to their cases, improvement in speed and timeliness of case processing, reduction in cases error rate due to more sophisticated automated benefit calculations and internal checks, improvement in timelessness of data entry for casework, reduction in mailings due to improved notice generation and processing, and in some cases, electronic notes replaced in snail mail. Reduction in other administrators' overhead by allowing clients to directly upload copy of documents instead of mailing them in. Better coordination with external partners to improve interfaces and reduce system downtime for maintenance and service. The department's plan is to look at this and other measures to perform efficiency and benefit evaluations of these efficiencies once the three major systems are fully implemented. But even as we discuss this type of anticipated benefits, it is important to remember our ultimate goal here. Are we able to serve our clients better after MDThink? Are we able to deliver for people in need? Did we give the workers the tools that they needed? With that in mind, I want to let the committee know that about another way that MDThink has already proven its value during this COVID-19 pandemic. PEBT benefits have been tremendous boon to families in need during this pandemic, and I think you would agree with me. And Maryland has been more successful than many states in this effort, getting benefits to more families and continuing them for a longer time. The legacy data system in many states struggle with the PEBT changes, and Maryland's legacy system, CARES, was also struggling. Fortunately, the MDThink team was able to step in and fill critical gaps to serve those families that our legacy system could not. And we were able to serve all of the qualifying families. This is the type of unanticipated but very tangible benefit that we're getting from MDThink. And we need to keep this in mind as we evaluate the efficiencies and effectiveness of the new platform and systems. This concludes my testimony and response, and I will be happy to address any questions the committee may have. Thank you.
Thank you, Madam Secretary. We're going to hear from the House Chair, Chair Resnick.
Thank you, Madam Chair. Madam Secretary, thank you for that presentation, and I appreciate and applaud your passion for MDThink. As you know, however, the unfortunately, the rhetoric is not matching the timeline. And the report from Grace only highlights my concerns on the MD Think platform, the same concerns I had literally a year ago when we met in my office with your staff. Since then, only one additional platform has gone live. I have seen no information that any of the issues with the long-term care application that had already been launched were resolved based on the comments and concerns I heard from the community that that is supposed to utilize that application. We have continued to spend obscene amounts of money on the development of this platform. We are now reaching, I believe, $500 million in development costs. And all of the promises I was made last year on the timeline that we had on the form that you were given, unfortunately, that document is in my Annapolis office right now and I'm at home, so I can't reference it. But we had much rosier expectations for the rollout of these applications. And we are still seeing that more than half of this system is not developed yet. So based on how long we've been talking about MD Think, based on how long, unfortunately, I feel we're going to keep talking about it, it is my belief that MD Think will not be fully rolled out and operational until the next administration. And that is very concerning to me because I do believe that we will continue spending money, federal or state, money nonetheless, on this platform. So I would like for you to tell me where the delays are in, since last year we met. And I understand COVID, and COVID has put everything, in a different perspective, but this is an online cloud-based platform that can be deployed anywhere. So I am a little wary of COVID as an excuse here. So please tell me when you expect all of this to be complete and what the final budget number is going to be, reminding everyone that I believe the original estimate was under 200 million. We are now close to 500 million. So can you please let me know when we expect this to be done?
Thank you, Chairman, for the opportunity to address your concerns, and also thank you for your continued interest on MD Think. To what has been rolled out, I'm going to have my CTO elaborate on that, because while we're talking about CGMs, many other things have also been rolled out that were not mentioned during the analysis. So I would like him to refer to those, and then we're going to come back to the cost.
And before you do that, just so that we are clear, CGMs is not entirely rolled out. The child welfare system portion of CGMs is rolled out, but not the entire application, correct?
Correct.
Okay, so that everybody's clear that CGMs is not fully operational. Please go ahead.
Thank you, Madam Secretary. Thank you, Chairman. Yes, on 2020, your question is like, what are the various things we have accomplished, right? Just want to make sure this group understands that every implementation is a multi-step or multi-phase process. It's not like you just go and turn on the switch and everything is going to be up and running. In 2020, we have deployed 14 different deployment has been happening. For the child welfare portion of the CGMs, which is the major portion of the deployment, during the COVID, the real challenge what we faced is we have to make sure all the caseworkers, all the field workers are getting the right equipment so that they will be able to make use of the system. So procuring the equipment, deploying them, training them in the new equipment is one of the challenges we faced. The second one is, initially, we have planned for all the caseworkers to come into the site to take the training so that they can have an in-person training. So because of the COVID, we quickly need to pivot all our training materials and training methodology to completely online. The third item is, initially we planned to do a on-site support for every development to the various counties. That also, we need to train over 3,000 workers to make sure in the event, if they have any problem, how they can be reached us, and we will be able to support in such a fashion that they will be able to process their cases or whatever the work they do. So these are like a basic three items I want to note to this committee. The second one is, during this complete deployment, there is an additional thing. Even though the adult services is not fully deployed, 21 jurisdictions out of 24 jurisdictions has been already deployed, and workers are using the system. Adult service, we do have slightly different challenge because adult service was not having any system prior. So many users are using the pen and paper to process the cases. Now we need to train them to use the new digitized version of the system. That is also kind of like a challenge we faced. We trained them and it is in use. Right now, only 3 counties, the Anne Arundel County, Baltimore County, and Montgomery County. These are the 3 counties still remaining. The reason is they do have some old system in place to process the adult service application. So we want to make sure all those information are also properly converted. So that kind of work is going on. And we are anticipating to deploy that like next month. The next major item in that CJAMS arena is the juvenile service. The type of work the juvenile service team or the department does is slightly different than how it has been performed in Department of Human Services. We learned that as we started developing, as well as they asked for some additional work. So we incorporated all those things. Right now, we are in a much better shape. We are planning to deploy that in this coming summer. So that gives us some kind of like a full-blown view of the CJAMS, where we stand on that. In 2020, I want to highlight 2 more items. One of the items is called Enterprise Content Management System. This system is a very siloed and independent system before our new deployment. So now what happens, we deployed this enterprise content management system, training all the workers, the FIA, the Family Investment Administration workers, as well as the child support workers, whoever uses the system. They need to log in a different system, upload all the documents, and there is no connectivity between that system and the legacy system. Now with this new approach, once you upload this document, you will be able to view and process the application in the new system. So that is completely deployed statewide in the last year, the 2020. The next one of the items is the provider portal. We already implemented as part of the pilot. Right now it is in a pilot phase. We are getting some kind of good feedback from the provider community. We are incorporating all those things and we are planning to deploy within the next few months. So these are all the various accomplishments of what we did in 2020, irrespective of this COVID. The next, your main question is when the design, development and implementation phase will be over. In the last year, we have done so many changes with respect to COVID into the eligibility and enrollment system. That is one of the major complex systems we are undertaken. So there are some specific changes also we implemented. We got some kind of challenges with our federal partners. They also introduced some new procedures for us to follow. It is good for us as well. Want to make sure the benefits has been issued to the clients or the constituents in the right fashion. There are some additional challenges with respect to that is they want us to perform some parallel processing. What does that mean? Pick any of the county like a pilot. That county, all the county workers has to process the application in the old legacy system, as well as do the same kind of activity in the E&E system. And then generate the report out of it, compare the result to make sure everything is good before you are turning on the switch. So that one was kind of like a new requirement they injected in the past couple of months. So we need to adhere to that. And also the additional challenge, Chairman, is because of a lot of COVID rules has been implemented in the new system, they want us to show the report, the outcome, saying what has been processed in the CARES and the E&E. We are having some level of challenges to generate the report out of the legacy system because the legacy system does not have that kind of flexibility or configuration available. But in the new E&E system, we are able to show the complete result, what is before COVID and after COVID, means like during COVID. What is the type of food stamp benefit amount is going to look like? After the COVID rules are turned off, whether they are going to get the right benefit or not. These are all some of the practical challenges we are facing. And in addition to all those things, on January 19th, we started our parallel processing. It has been 4 weeks and things are going very well. And within next few weeks, we will be turned on in at least the initial pilot counties. So that is what we are hoping for. So overall, by this summer, we will be able to go statewide for the eligibility and endowment system.
So my question was, when is the whole thing going to be done? And by the sound of your presentation, it sounds like you have no idea when it's all going to be finished.
Sorry, Delegate. Yes, all those things is going to get finished by early of next year, early 2022.
Okay. Just a reminder to this committee and to you, last year, you told me that everything will be done by this year. So we're now pushing it 1 more year. Thank you very much, Madam Chair.
Thank you, Mr. Chair, for your questions. We have 2 additional members who have questions so far. Senator Eckert, followed by Delegate Young.
Thank you very much, Madam Chair, and Mr. Chair, co-chairs today. Secretary Padilla, thank you so much. I know this whole technology system has been very important to you and to the department, and you've heard us talk about Chessie many times. So thank you for your work so far. And I'm interested in getting it done yesterday rather than several years from now. I think we all are. But my question has to do with DO-IT. I think DO-IT's only contracted to be with you to participate for a certain period of time. First question, is that correct? And then what adjustments are you anticipating will need to be made in relationship to having DO-IT continue on the team? I guess that's the best way to ask that question, but I'm just interested in what we can do to help you to make this all happen. And I know we've had a little COVID issue, but that's been, from what I understand by listening, that's been a good thing because you had to step up and do some things that maybe weren't anticipated, but then it does slow some other things down. So 2 questions, the role of DO-IT, and then what kind of arrangements have to be made for that adjustment, if there is one. Thank you.
Thank you, Senator, for your questions. DO-IT has oversight of any projects that are in development. So while the different modules are in development, DO-IT has oversight, and we work hand in hand. Our relationship is very close. We have weekly meetings. The secretary and I, we have meetings also to compare and discuss any roadblocks that could come up. But then when we move to the maintenance and operations of the module, then DO-IT will no longer have oversight, and then it would only be DHS. And I want to get this right. And if Greg, Deputy Secretary James, if you you need to elaborate on that part, please do so.
No, Madam Secretary, I think you stated it very well in terms of relationship to the oversight as relates to
Right.
MITDP fund. Certainly, as the Secretary mentioned during her testimony, when it comes to other applications, other departments' applications coming onto the platform, then we collaborate with Do It very closely on that for their evaluation. Projects go through the Do It intake process for evaluation to determine whether or not the MD Think platform is an appropriate fit. And we continue to collaborate with Do It overall in terms of the path and future of the platform, along with other major stakeholders, including the Health Benefits Exchange and Department of Human Services Department of Health, Department of Juvenile Services, all of whom have applications on the platform. So certainly, yes, that collaboration is going to continue regardless of whether or not there's funds associated with the platform or not.
Okay, I guess that was my question. Thank you. I'm trying to figure out that if we don't get it rolled out by the end of 2022, and is his contract kind of finite? Is it time limited? But if you still haven't finished it, Do It will stay involved, right? That's the answer. Do It will be involved no matter what until you get it finished. Excuse me.
Senator, if I can get back to you with that specific answer, I don't want to misstate the mechanics of the MIDIP fund, but certainly we will continue to work with Do It very closely, regardless of the status of that formal oversight center.
Thank you. I think that takes care of it, and we're all interested in that response. So look forward to getting that feedback for the committee. We have a final question from Delegate Young.
Thank you, Madam Chair and Secretary. I wanted to part of my question was asked by a good friend senator from the Eastern Shore, so I still would like more of a clear answer too. I've been on this committee since 2015, and before this project was being funded, and when it started being funded in 2017, I know there have been multiple challenges. It's a large department. It's an important project. Many of the issues that your office has been very forthcoming with me in solving and discussing throughout the years all then go back to the implementation of the platform. So I share my chair's concerns and frustrations with again, another date being pushed back, because there have been many, and there have been some understandable and some hard to understand delays. So my question was going to be, if we don't meet the next deadline, what's the move forward? How does that affect? And I think Senator Eckert brought that up, talking about Do It and what their role is if we don't meet the next deadline. And on top of that, I just feel that since it's another year being pushed back, do our committees need to play a more active role in oversight with this, coming up on $500 million in terms of funding? Do we need monthly progress reports? Do we need to play a more active role from now until there's that final date where we're done? I may already know the answer to that, but I just throw it back to you for your comments and answer to the question. Thank you.
Thank you, Delegate. I can tell you that we have been providing reports to DLS on expenditures, on progress, on timelines, all that you were referring to. We don't walk away from oversight. I think to your comment, it is a project that a lot of money has been spent. But let me give you a little bit, give you a different context to what you just said. Because while we feel that a lot of money has been spent and a lot of time has also been spent, I want to start by saying that first, when we thought of the initial inception of MD-Think back in 2015, I came in 2017 and we had just received the approval, right? And that was based on a very limited application modernization. So what was then and what was now, it has changed because we have identified this unique opportunity that I don't want us to underscore how much we in Maryland need to modernize our IT system. And, it's an excellent opportunity that we are also getting funding from the federal government. So when you look at the split, as the analyst said, I mean, 336.9 million federal funding compared to 111 general funding is big. So of course we needed to pursue this opportunity and make sure that we modernize as much as we can, because it is so much needed. And really the Delegate Resnick, Chair, mentioned my passion. It is my passion because I see it every day. I see the workers, the struggle that they go through on a day-by-day basis and how much is needed, and moving it from the workers and moving it to the people that we serve, how much is needed by the people we serve. So that's why it's so important. But I can tell you that I have done some research on what is happening in other states, right? And in other states, just take just one, I'm going to pick on the eligibility system, the E&E, that we made reference. In the state of Rhode Island, they spent $490 million just on the eligibility and enrollment, and came with a lot of troubles. In the state of Indiana, they spent $300 million just on E&E, and we're doing 3, okay? In the state of Vermont, $150 million. In the state of Ohio, $1 billion with a B. Just one system. And in child support, 367 million in Texas, and it's still not implemented. And Florida, 250 million. Child welfare, which is the one that we have completed, 230 million in Michigan, and they're ready to walk away from it because it's not working. So 100 million in North Carolina, and they're struggling with the implementation. So I want us to be kind to ourselves and celebrate our successes, because Maryland has been successful in rolling out, and will continue to be successful in everything. Thank you so much.
Absolutely, Madam Secretary, and I'm looking forward to celebrating with you all with the final success of it being implemented. And it was sort of baked into my question. And now that we don't have that final date of implementation, but we know that there's going to be hiccups with rolling out. It's just inevitable. So part of that question that I think Senator Eckert came out of her question as well was, what happens after that implementation date, and what's the role to fix these hiccups, these issues that will inevitably come from it? Because and I appreciate and applaud your efforts, and knowing that we can't walk away from this, because in the long run it will save money. In our oversight role, I just want to make sure that you recognize that we're frustrated on our side, and I know that you're working on your side, and look forward to celebrating successes once we reach them. Thank you, Madam Secretary. Thank you, Madam Chair.
Thank you, Delegate. Well stated. I don't see any additional questions. Madam Secretary, I think you've heard from the committee in both chambers, or the subcommittees, a desire to see this advance with a timeline that is predictable. We all know that there's a lot happening and a lot of moving parts, so please keep us posted. And we look forward to hearing the response back on Do It and their engagement from your deputy. With that, members, seeing no further questions, that concludes today's hearings. Thank you all so much. Thanks to the analysts. Thank you, Madam Secretary. Thanks to the members for your questions and commitment to advancing these important efforts. Have a good afternoon.
Thank you.
Thank you.